And I'm going to first start out talking about optimizing care for pelvic floor disorders among minority women. And I first want to acknowledge some real leaders in this particular field of interest. So Raveen Sayan is my colleague at University of Miami, Ya is at University of Washington, and Akene is at Stanford. And I want to give them credit for some of the slides I'm using and the data. So first we're going to talk about disparity research in general, and then more specifically about pelvic floor disorders. So health disparities by the CDC is defined as preventable differences in the burden of disease to achieve optimal health experienced by socially disadvantaged populations. So this is a model looking at the different layers of racial disparities and what goes into this. So first, there are contributions from health, predisposing factors, age, race, insurance, education, income, comorbidities, access, and physician density in their area. Socially, economic stability, physical environment, education, food sources, community context, and healthcare systems, and structural components, systemic racism, institutionalized racism, and economic systems and social norms also. So in the past, when we look at equity research, public health research has really looked at just defining disparities and the incidence and prevalence of disparities and the issues surrounding that. Right now, the present and kind of immediate future, we're looking at underlying causes of disparities and trying to develop interventions. And in the future, we hope the clinical research will be able to test interventions with human subjects to look at this equity, these equity barriers. So in general, why do we care about pelvic floor disorders in the context of disparity research? So, that's because it's highly prevalent. I've talked about this before in previous lectures, but, this is just a study looking at pelvic organ prolapse, fecal incontinence, and urinary incontinence, and 30% of women in the general population experience one or more pelvic floor disorder. And it has significant impact on quality of life. Again, I've mentioned this before, but 40% of UK men and women with symptomatic overactive bladder always worry about frequent bathroom trips. It affects their work and number of hours that they spend at work. And 7 to 10% of patients report that it's a severe problem and quite debilitating. So, and I've also discussed that we really are, the treatment rates are low for pelvic floor disorders. So we really need to catch these patients, educate them, and treat as well. So what do we know about disparities in pelvic floor disorders right now? So there's been multiple studies to suggest that the prevalence rates are as high, if not higher, among certain minority populations. Particularly, this is an example of a Hispanic population that's pertinent for South Florida, which we'll talk about our research with that population. But 33% of patients have urinary incontinence in general for Hispanic ethnicity compared to white, and that is kind of across the board with other research as well. Among the Chinese population, there's also similar bother related for urinary incontinence, but a little bit different as well and more severe among minorities. So despite similar-ish and sometimes higher prevalence or bother, minority women are less likely to receive treatment for their incontinence. So this is an example from our group looking at advanced therapy for overactive bladder, and non-white women are much less likely to receive advanced therapy. And for stress urinary incontinence, minority women are significantly less likely to see a specialist and receive treatment as well across the board in minority populations. So why are they not receiving treatment compared to non-minority patients? And we've looked at severity of symptoms, and those are similar, so it's not that. We have studied socioeconomic barriers and length with different database studies, so we've already looked at that. But now I think we're kind of changing our tune and changing focus to look at things like care-seeking attitudes, provider bias, lack of knowledge from the patient, and social determinants of health. So what are social determinants of health? We love to throw on this word sometimes. And these are conditions in the environment where people are born that are wide-ranging and affect quality of life outcomes and risk factors. So they include healthcare access and quality, neighborhood and built environment, social community context, economic stability, education access, and quality. This is from the U.S. Department of Health and Human Services. So in particular for pelvic floor disorders, we've examined social determinants of health, and when we're controlling for different things like site, age, race, BMI, parity, and previous pelvic surgery, we notice that there's higher OAB symptom burden that is associated with food insecurity, financial strain, difficulty finding or keeping employment, and difficulty concentrating. This is a study looking at discordance of language between provider and patient. I think this is so crucial, again, a little bit more pertinent for where I practice, but barriers include behavioral adaptations to language discordance between the provider and the patient, and interpreter use barriers, time constraints, and accommodation between patient and provider. So I think we really need to acknowledge this and look into this more. So there can be significant environment and social factors that disproportionately affect minority women. And there are differences in care-seeking attitudes as well. So this study showed that minority women were less likely to seek care for urinary incontinence compared to white women. And more specifically, among the Asian population, only 34% reported seeing a doctor for urinary incontinence compared to 56% of white women. And obviously there are many factors that play into this. So examples of differences in care-seeking attitudes include a lower income, patients with diabetes, and Black race. And there's also a significant lack of knowledge and awareness among patients of pelvic floor disorders. So African American women were less likely to understand a relationship between childbirth and urinary incontinence, and other women of color were also less likely to know about risk factors, preventative strategies, and treatment options. So the knowledge is different among minority and non-minority. In our group, we've looked at, in particular, we have a Hispanic predominant patient population in South Florida, in Miami-Dade County. So we were looking at the patients that were unaware of treatment options, and 50% of Hispanic women were unaware, 40% of Black women were unaware, significant difference in our patients. This is another study that we presented at ICS in Madrid, and we're looking at, again, primarily Hispanic patients. These are the demographics, and we're looking at patients that elect for surgery versus patients that decline surgery. So interestingly enough, older patients are declining surgery, and patients that are offered surgery for overactive bladder are more likely to decline surgery as well. But issues that came up during this qualitative analysis included patients that did elect for surgery, stated that they were comfortable with their physician, they wanted to receive definitive treatment, and they believed faith pointed them in the right direction for electing for surgery. They reported friends with similar experience, and patients that declined surgery reported concern with physical appearance, history of negative surgical experience in the past, and they were more familiar with medication options. So these are some quotes from our patient population, and the desire to receive definitive treatment drives their medical decision making, and faith really does play a big role among our patient population, and these are just examples of quotes that we had. So minorities feel more confident in their treatment decisions when they feel comfortable with their physicians, and they also do, we found that they lean upon the influence of their faith in their community. Physician counseling and bias also plays a big role among this patient population. And so other steps that we, again, can look at, and, so this is what we've learned, but what can we do in the future to change this? So University of Miami, we have this game changer. These are mobile clinics, mobile healthcare clinics. And really, I think it's a partnership with community and engagement. So the hope is with these mobile health clinics to address barriers with social determinants of health and tackling health issues in a community-wide level to improve access to care and in particular, obviously, just educating patients as well, that patients don't have to suffer from their pelvic floor disorders or whatever it may be. So this is used across the board at University of Miami, these game changers, especially for cancer surveillance and screening as well. And what we also need. So we need to continue to listen to patients to understand barriers to care. So we should utilize qualitative methodology with examples like semi-structured interviews. So it's not your typical research when we think about this. And we kind of have to come up with a different cap when we're thinking about how to tackle this, I think, with focus groups and with ethnography as well. So I think it's just an interesting area compared to what we normally think of for urology. A patient-centered and community-engaged approach is our key really to creating equity in the care we deliver and outcomes that we can achieve. So beyond engagement, I think it's obviously important to prioritize research questions, develop partnerships and advocate researchers, and continue to design and conduct research studies. So these partnerships are really crucial to target these patient populations that are in need and develop more trust with these patients and education. So what can we do as clinicians in the audience? Just support community-based medical efforts, I think, is very important, and hopefully we can continue to fund community-based research in these areas. So thank you.